Good morning. This is Suzanne Dion from Harmony Place, Monterey. I want to welcome you to our first of 4 of the webinar series. And this morning we will be entertained and educated by Dr. Stephen Southern. What I'd like to do is introduce him by reading his bio. Dr. Stephen Southern previously taught at Northwestern University, Texas A&M University, Corpus Christi, the University of Southern Mississippi, University of North Texas, and Temple University. He's a licensed psychologist, Illinois and Pennsylvania. He's a marriage and family therapist from Mississippi and a professional counselor also from Mississippi and Texas, as well as an AASECT certified sex therapist and clinical fellow in AAMFT. Southern is an approved clinical supervisor. Dr. Southern was trained at Masters & Johnson Institute and served as clinical consultant in the treatment of sexual dysfunction, trauma, and addiction. He developed an integrative program for concurrent treatment of trauma and addictive disorders. Southern was previously editor of the Journal of Addictions and Offender Counseling. Dr. Southern is editor-in-chief of the Family Journal on Sexual Addiction and Compulsivity. He has over 70 research and professional publications. Dr. Southern is the past president of the International Association of Marriage and Family Counselors and received their Lifetime Achievement Award. Southern is a fellow of the American Counseling Association. He received the Legacy Award of the Association of Counselor Educators and Supervisors. Dr. Southern served on the board of the International Association of Marriage and Family Counselors, the Mississippi Association of Marriage and Family Therapists, and the Society for Advancement of Sexual Health, also known as SASH. This webinar is approximately 2 hours long, and once you've completed watching the webinar, if you would fill out the online evaluation form to receive your 2 CEs. Each of the 4 webinars of this series are worth 2 CEs, and you will get a certificate for each one independently. There are 2 handouts that go along with this webinar. There is the PDF of the PowerPoint that he's completed and will be showing today, and also a PDF article that was published in the Journal for SASH, and that has been sent to you too, on the treatment and recovery of sexual compulsivity that he has co-authored with Dr. Mark Schwartz, also formerly of Masters & Johnson's and now the director of Harmony Place Monterey in Monterey, California. Dr. Southern, whenever you're ready, you can go ahead and start.
I apologize for the delay, and also these conditions are a little extreme. It's a beautiful sunny day here in Monterey, and I really appreciate that, except I have a lot of the sun in my office. I tried to move, and I think there must be a lot of metal in that office blocking the Wi-Fi. So I appreciate your patience. And I'm very interested in sharing with you some of our work on treating sexual compulsivity or sexually compulsive behavior. I wasn't on the session earlier to hear the introduction, but I'll just add a few things. I've been working in this field for probably 35 years. It extends back to the time whenever Mark Schwartz and I were in New Orleans, and we set up probably the second treatment program for treating what we call sexual compulsivity. Patrick Carnes had set up a program for treating sexual addiction at Golden Valley Health Center. This is probably in around 1985, I would say. And Carnes had come out with really the first book. It came out in '83, and then the second version of it was called Out of the Shadows. So we began to collaborate, several people who were interested in this sort of new field. And we worked also with Eli Coleman from the University of Minnesota Medical Center and their program in sexuality. And then slowly over the course of several years, there began to be a number of other clinicians and faculty members and so forth who were kind of interested in looking into this phenomenon. And it's evolved over time to where there's a lot of controversy nowadays regarding what is sexual addiction or sexual compulsivity, and then how could it be treated. So I hope we can explore some of those, but also get some practical, aspects of it too. I'm not right now. I don't have a way to see your various remarks. I wanted to have an active session where you could type some questions and so forth. We may actually have to, let me see if I can get the Q&A up, because I don't want to just be a talking head, especially in this awkward position I've assumed in this room, and then just show slides. So if you do feel like asking any questions, I've got it opened up again over here, the Q&A box, and I'll try to, address some of those questions as we go. So that's my plan, and I'm sticking to it for now. So we're going to look at some of the common characteristics of compulsive sexual behavior and across some of the various models, classic models as well as contemporary models. And then I'll describe some of the current treatment approaches. And then ultimately some of the tension that might arise from looking at sexual addiction nowadays, some of the conflicts and controversies. I think it could all be resolved in terms of basically agreeing that we should try to promote sexual health in ways that persons themselves define their own sexuality. So over 30 years, it's been a pretty robust journey. The addiction model of Patrick Carnes was based on the 12 steps and 12 traditions of Alcoholics Anonymous. Our model was based pretty much, the sexual compulsivity model of Masters and Johnson Institute was based on an assumption that there was some underlying trauma that had somehow disrupted development of sexuality. And so there were expressions then of sexuality that created consequences and required attention. And then Eli Coleman's model also addressed how sexual behavior may be used for non-sexual reasons, such as coping with anxiety or reducing depression, expressing anger, or that in fact the sexual behavior itself might be better explained or more parsimoniously explained by underlying mental disorder. So it is, an idea that has persisted over time. In recent times, more controversies about whether or not sexual addiction even exists. And I think perhaps the best argument of detractors has to do with whether or not we're constructing this biased, rather conventional view of sexuality, and in doing so, maybe pathologizing lifestyles of persons who would like more freedom of choice. So that's kind of the backdrop for looking at this topic of compulsive sexual behavior. Here are a few examples, and I always like to go to the reality of a case and how that person experiences their own sexuality. So some of these are descriptive of, amalgams of actual clinical cases, no one in particular, and then others are just sort of good examples of what might be considered sexual compulsivity. So if a teenage boy were to lose all interest in school and friends and, extracurricular activities, dating and so forth, because this person is consumed by internet porn. And consumed by internet porn implies that a person would spend many hours in a day and a week surfing the web and looking for content. And there actually is a process by which someone becomes bored with things they've seen a lot, and they move on to things that are more novel or extreme. So in terms of the idea of maybe a progression in the old sexual addiction construct, you could argue that when someone moves from sort of conventional, middle of the road, partner-oriented type of explicit sexual content online, and then they get trapped in the web and end up visiting child porn sites or some other site that is either illegal or is completely incongruent with the value system, that sort of describes a little part of what I would consider to be, for that person, a progression. Or a college girl, I'm using here a woman, who loses herself and dignity after disappearing into the BDSM scene and then being traded as a sex slave and so on and so forth. And, that is a culture or community, and there are people who enjoy BDSM and they're completely consenting, and it is a lifestyle option, so we don't want to pathologize it. But on the other hand, if someone feels trapped if they feel as though they have been suffering harm, if they feel like it's something that has made a big impact on their lives, then we would like to offer them some support and assistance. Or another example, a Sunday school teacher who is, masturbating in the full view of the living room window. This would potentially, be incongruous again with this person's value system. And then in this case, arguably the masturbation could be in the form of perpetrating, some type of crime of exhibitionism, something along that line. And then I'll just skip down to a few of the others here. A doctor who is impaired is referred to an impaired physicians program after taking indecent liberties in physical examination. And when I formerly worked in Mississippi, we had a impaired professionals program, and we actually had cases like these where doctors were driven, in a sense, by their unresolved sexual issues to do unnecessary or inappropriate physical exams. Sometimes the patients would be unaware, and at other times, typically when they would come to our treatment program, they would have been referred because someone made a complaint. Again, that could be viewed as not only indecent liberty in the old terminology, but may also constitute offense. And I do want to say, in anticipating a future slide, we're not trying to create a condition in order to excuse illegal behavior, because that has been one of the criticisms. And I think given our recent cultural experience with Me Too and so forth, the sexual addiction should never become like a respite for, psychopaths or persons who are intentionally, abusing power and committing crimes. So we'll get back to that topic. And if any of you have a question or comment you want to make about that, I'll try to share that faithfully. Okay, and then here's another quick example, and we'll be moving on in just a moment. But you have a secretary or administrative assistant who, in fact, loses her job because she spends most of the day on the internet and then leaves work in order to hook up with somebody she's located on Tinder. So you say, well, she's just using bad judgment. She's a bad employee. She has, mental health problems and so on and so forth. And all of those are plausible explanations for the behavior. But if she were to come for an assessment and she says, I just can't stay off of this site, and I'm preoccupied with it, and I find that if I don't visit the site, then it affects my ability to concentrate, my mood, and so forth. And then when she does get on the site, ends up with these hookups and stuff, and possibly creating potential for harm to herself, or maybe harm to other people. So these are all kind of dimensions that may apply to this idea of sexual addiction or sexual compulsivity. So I'll leave this for your reading later. If you need some examples, maybe if you look at it later and you care to make a question or make a comment, then this will be a source. Let me see if there's anything on there. All right. Okay. Whoops. So this is the ASAM, American Society of Addiction Medicine, definition for addiction, and it also is very robust. It takes into account that there's brain reward systems that are primarily dopaminergic that provide very powerful reinforcers for the use of substances, but also engaging in certain behaviors. And sexuality can be a very powerful reinforcer. By reinforcer, in this sense, it's really positive reinforcement. And when you have that strong reinforcement after looking at, let's say, pornography, then it increases the likelihood that you will return, to that site in the future. So you increase the behavior based on this reward circuitry. And then that's the high side of addiction. And then the low side of addiction, and especially if there might be a progression, which is predictable in substance use disorders, then after a while, it's not the high side of addiction that creates motivation, but it's the low. It's trying to avoid internal aversive mood states, emotions. There may be depression, anxiety. And for some persons who are troubled by their compulsive sexual behavior, they actually discover relatively early that the involvement in the compulsive sexual behavior maybe helps to ward off a pre-existing depression. So the depression is not necessarily an outcome or contingent upon having been involved in compulsive sexual behavior, but it's just like taking a drug that temporarily at least circumvents the pre-existing depression. So the ASAM definition is very robust, as I mentioned, and it could have been used in the DSM-5, or we could look at it, in terms of various behavioral addictions, but we're going to discover that there's only one recognized behavioral addiction. There's another one about to be recognized in a revision of the DSM, and unfortunately, behavioral addictions are what are sometimes called process addictions. They're not widely regarded in the medical or psychological community as being valid. So I hope I'm being fair to this, to this presentation. I want to give really all different perspectives on, what may be sexual addiction or compulsivity, or what it is not. So Braun Harvey has a construct, and Vigorito, of out-of-control sexual behavior. And in a lot of the sexuality therapy community, they sort of like this diagnosis because it's not based on any type of pathologizing or necessarily any kind of underlying theory. It just sort of is very descriptive, and I think that's appropriate. But sexual addiction or compulsivity should, as a construct or as a treatment process, should never be used to oppress sexual minorities or deprive individuals the freedom to express themselves as they see themselves as sexual beings. And then, as I mentioned before, sexual addiction should not pathologize diverse sexual behaviors, because there's a great deal of diversity, in these times. And I mentioned earlier BDSM. So there are persons who are entirely happy with their lives. They view this as a pastime or a lifestyle or a recreation, and they may derive some gratification from expressing aspects of their identities, their personalities in the scene, as it's called sometimes. So it's not as though if someone gets involved in what would be considered BDSM, bondage, discipline, sadomasochism, that in and of itself is sexual addiction. And I think, unfortunately, that was more the case in, a few decades ago, is that anything that was viewed as being variant from partner-oriented sexuality, and even, heterosexual or heterosexist bias could be considered an expression of sexual addiction or sexual compulsivity. So we want to be careful not to pathologize the lifestyle of people who are free to choose, and they are not suffering adverse consequences and really don't want to change their sexual expression. So now another is sexual addiction should not be used as a cover or escape for unacceptable or illegal behavior. I've already mentioned, the illegal behavior. So we wouldn't want someone who has abused their power and engaged in sexual assaults or harassment to suddenly claim I couldn't help it, because I have sexual addiction. The person is 100% responsible for his or her or their behavior, and especially when it violates boundaries or it results in illegal behaviors. Another good example would be the problem of infidelity, and again, in myriad forms, but cheating or infidelity, or it's a fairly normative behavior in our society nowadays. And also, we wouldn't want to necessarily just use as an excuse, well, I got involved in this, let's say, extramarital affair, but I couldn't help it because, you know, I'm a sex addict. Sexual addiction may be involved, or it may not be involved, but it wouldn't be good to use the explanation of sexual addiction in order to further avoid or cover up or somehow camouflage, you know, a problem of boundary violation. And that's really within the context of the couple's view of their own relationship. And then finally, and I think this is very important in order to present a balanced presentation, is that porn and sex addiction, it can be used as a explanation, or even, let's say, an excuse for offering sexual addiction treatment. So David Lay and others have complained that maybe persons who offer treatment for sexual addiction have created and advocated a problem or a disorder so that they can offer treatment, which may be lucrative to the treatment providers. And I don't think I have a lot of comment on that, but I think it would be something definitely to reflect upon. This is the American Association of Sexuality Educators, Counselor, and Therapists, and I'm a member of this organization, and they do have a position on sex addiction, and it's very important to take that into account. And of course, there's too much here to read in this brief presentation today, but I would highlight the, let's see if I can get a little pointer on it. Yeah, so I'm right here on number 1. AASECT doesn't find sufficient empirical evidence to, let me move my Q&A box, to support the classification of sex addiction or porn addiction as a mental health disorder. So first off, AASECT does not believe or does not find enough evidence to support this as a disorder. And number 2, it does not find the sexual addiction training and treatment methods and educational pedagogies to be adequately informed by accurate human sexuality knowledge. I will say, and this is an opinion, and it's my personal opinion, it doesn't reflect Harmony Place, Monterey, which has arranged this webinar series in which I'm participating. It doesn't reflect my position as an AASECT member or a member of any other organization. It's just a personal opinion. But I do think that based on my years of experience as a sexuality therapist, that in sexual addiction treatment, there is a lack of knowledge of what constitutes sexual development and healthy sexuality. And also there's a lack of training and supervision in the clinical approaches to improving sexual health. So I think there's some organizations who are in the process of trying to increase the sexuality knowledge and training and supervision for persons who might offer sexual addiction treatment whenever it is requested, you know, by a patient or family member. But I think that, I guess what I'm saying is I think there's some validity to that concern. Ultimately, you're the arbiter on, you know, what constitutes sexual addiction, and I will leave that up to you to make that decision. All right. I haven't seen any questions or comments yet, and I don't know how many people may be on board, but I guess I'll keep going.
Stephen, this is Suzanne. You do have one question that's come in, and it's from Brittany, and she says, hello, Professor Southern. Were you saying that if someone is happy with the lifestyle, that it does not constitute as addiction?
Okay, Brittany, that's an excellent question. And I think that if a person is free to choose a lifestyle, and that's a complicated idea, but let's just leave it at that. And if they engage in the lifestyle and do not suffer negative or adverse consequences, and in fact, if they say that they derive satisfaction and meaning from their sexuality, and if it does no harm to another person, it's kind of hard to say that that is a disorder or that it would necessarily constitute addiction. The second way I would answer the question is I'd fall back on the ASAM and other addiction criteria. You know, does a person experience powerlessness and unmanageability, which means they don't really have freedom of choice? And then the consequences, do they in fact suffer some negative consequences, include violating their own value system? So we have to take that into account. Is there a progression from something that's relatively fun or benign towards something that is, somehow more problematic? So the idea of progression is maybe part of tolerance, which is an idea in addiction that I think applies. So you just have to look at the individual case. So some people who are on the high side of addiction and they're spending 12 hours a day on the internet and they like the porn they're watching, they say, this is not a problem for me, I love it. Well, I would start looking into it, because it more than likely there's a drivenness there, a powerlessness, an unmanageability, and I would want to help the person maybe become more aware of how it's impacting other aspects of life. When that occurs, we would want to use probably the stages of change model or the trans-theoretical model, like in motivational interviewing or motivational enhancement therapy, to help somebody who basically might be engaging in addictive behavior, but they're very much in the high side, so they don't see any reason to stop. So that's a long-winded response, but hopefully it covered a lot of territory. And thank you for asking that question. All right, I don't know if you can see all my pop-ups in here, Monterey Bay Aquarium and so forth. Okay, sexual addiction as behavioral addiction. I mentioned earlier, there's only one in the DSM. So you have a whole section after substance use disorders that could be addressing, non-substance behavioral type of addictions. And there's only one, and it's gambling disorder. And gambling disorder is established in the DSM primarily based on the neurological evidence from CAT scans and PET scans and a lot of scientific investigation, which shows how the brain is altered in individuals who begin to have problems with gaming or gambling. So I think that was the persuasive part of the consensus group for the DSM, is that they found that there was a lot of in effect, medical evidence for a gambling disorder. Now, if you remember in the DSM-4 and the text revision, gambling disorder had kind of a journey. It started as an impulse control disorder. I think it was called pathological gambling. And then it kind of evolved into this full-fledged, what I would call behavioral addiction. And it does create room then in the DSM, although a lot of folks don't like the DSM, but it does create room in there for something like sexual addiction and compulsivity in the future. We'll find in a moment that the ICD 11 panel with WHO, that they're going to include compulsive sexual behavior disorder. So I see another question here, and I like questions, so let me get to this one. Javier said, these are excellent questions, by the way. Hello, I'm an ordained minister and a pastoral counselor. All of my clients are members of the clergy. Most of my clients grapple with trauma, process addiction, and intimacy issues. How do we get them to resolve the shame to avoid the anonymity and to go ahead and come into treatment? So, that is, coming out of the shadows, or, beginning to have a voice and expressing, one's pain and so forth, overcoming the pain and shame from the past. And I think it is really very complicated problem. And a lot of people do associate certain sexual behaviors with sexual addiction because it violates some of their religious beliefs and in particular faith traditions. So like if your faith tradition said that you should only engage in sexuality in the context of a marriage, then there might be a broad range of behaviors that would fall under this problematic sexual behavior and could become, identified as sexual addiction or sexual compulsivity. Now, I've got a couple of statistics, one that's documented later in the slides, and the other one, I don't think I have a citation for it. I could probably find it. But I believe that on any given, let's say Sunday in the Christian faith tradition, that among the men who are sitting in the congregation, as many as 70% of them may have viewed something that could be construed as pornography. And later we'll see that among the clergy that there might be as large a group as 40% who are struggling with this problem. That's why in the seminaries, they've begun to really include attention to sexual boundaries and violations of those boundaries, or what constitutes sexual health. And so I think to answer the question now, it's in any training of the clergy, there should be attention paid to sexual addiction and compulsivity. It should be viewed, I would say, as an occupational hazard. And in that sense, it kind of normalizes the risk of, becoming involved in behavior that inhibits or conflicts or actually interferes with their pastoral or duties or their role as a worship leader. So a lot of churches have done a great job in sort of allowing some of the 12-step sexual addiction groups like Sex Addicts Anonymous, Sex and Love Addicts Anonymous to have space in their facilities. And I'm just thankful that you as a minister and pastoral counselor, that you're out there in your faith tradition and in that community, and you're making yourself available to the clergy. And I would imagine that you would have a lot of potential referrals, and they do need that privacy, I think, before stepping into a group. Once in a while, it helps to leave the area and to go get help, maybe in one of the good treatment programs that exist around the United States, so that there's a freedom to, explore their sexuality without having to fear the negative influence on their ministries. So I think that's the way I'm going to answer it. It's a very profound issue that you're raising, and I know that doesn't, do justice to how important a topic it is. But this idea that in religion certain sexual behaviors are prohibited, that may turn out to be really important in understanding what is sexual addiction or compulsivity. So we'll come back to that in a few minutes. I hope that's an adequate answer. If y'all would give me a little encouragement and say, okay, that's good, I would appreciate it. If not, I'll come back, try to do another job. All right. I appreciate this, by the way, because, I'm a teacher for many years, just coming back to clinical work and rejoining my colleague Mark Schwartz and also Lori Galprin here at Harmony Place. But as a faculty member and teacher, I really enjoyed sharing, what it is I've been able to gather in knowledge. And so thank you for this opportunity to sort of teach for a minute. So here's gambling disorder. I won't really spend a lot of time here because I think we need to be moving on, but you can look at those diagnostic criteria and you see that there are some that are very characteristic of all addictions, like the AASECT criteria. And then you see that some are more commonly associated with this problem of gambling, like chasing losses over here. Let's see if I can highlight that. Yeah, that's very characteristic of later stages of gambling disorder. Of course, all addiction involves maybe lying or concealing or attempting to cover up. And then, back to the idea of jeopardizing significant relationships, like in the case of, some type of infidelity or boundary violation, or a job. And so back to the clergy item, it may be impossible for someone to continue their calling or ministry because of the problems then with compulsive sexual behavior, especially whenever they become problematic or if they get into the media, things of that nature. Okay, trying to go down and see if there's another question there. Okay, thank you. All righty, so I'm not going to go through all of this. It's there for your future reference, but it may be that if sexual addiction or compulsivity or problematic sexual behavior or hypersexual disorder, if any of those terms are ever accepted in the DSM, it will be like a sibling of gambling disorder. That's what I'm trying to say. And then here's another one, internet gaming disorder. I think in the upcoming revision for the DSM that they're going to include internet disorder, and they may include the gaming disorder, which was in the appendix. So I think there's an increasing awareness that in our society at this moment in time, that there's a fairly large numbers of persons who suffer from being unable to detach from their screens or devices, and that in using the internet excessively or engaging in some of the gaming that usually is associated with the internet, although it could be, some other medium, but that it's, producing consequences, and that's what makes it change-worthy. So recently, when I was teaching at Northwestern, and by the way, this presentation I'm making was based on a grand rounds that I did there, I think for the Center of Applied Psychological and Family Studies at Northwestern. And when I was teaching, I was teaching addiction treatment, and I challenged our students to find some kind of behavior that might be considered addictive. And for those who really had never known someone or struggled themselves with like alcoholism or substance use disorder, several of them chose their social media or just using their telephone, or how often they spent time on the internet for non-work, non-school related reasons. And let me just share this with you, because they monitored this over half of the semester, and they looked at the effects on their mood, on their relationships, on their ability to focus on their schoolwork, and so on and so forth. And the folks who were struggling with variations on this theme of the internet or the screen, they were among some of the most distressed persons in the whole experiment. And they really remarked how revealing that was. And it's a great training program there, and they're trained to be reflective clinicians and practitioners. So it really, really helped them to see that, this internet could pose an obstacle in their lives and in their work and in their own professional identity, because it was in effect constituting, maybe a form of behavioral addiction. So here are several of the classic models. I mentioned Carnes. They're in 83, sex addiction as a disease. And the disease concept seems like it holds up pretty well, at least in a descriptive sense. Masters and Johnson and Dr. Mark Schwartz and Lori Galpin and Dr. William Masters there, they published an article there on sexual compulsivity. I think we started around about 1985 with our sexual compulsivity treatment program at Joel and Smith Psychiatric Hospital in New Orleans. And then Eli Coleman, who continues. I'm the editor of Sexual Addiction and Compulsivity, and we have an upcoming article by Coleman and some of his colleagues and students that describe the state of the art in terms of their perspective on sexual addiction. So you may want to search for it. It'll probably be another month or two before it's available online. Okay, and then the contemporary models, mostly sexual addiction constructs were built on the experience of men. And so the whole field was sort of associated with men who were stepping out, were doing secretive behaviors. It may be pornography, it may be escorts, it could be, going to rest stops or truck stops, things of this nature. But over time now, there's been a lot of attention paid to compulsive sexual behavior among women. And that was very important to sort of make the field a little more gender fair. And there are some similarities, and there are also differences between men and women, or masculine and feminine individuals, and how problematic sexual behavior may be manifested. And we'll come back to that in a minute, because one of the things that's really impacting my perspective and my work is that I want to be as open as possible to understanding the lived experiences of persons whose sexualities are different from my own. And being an older clinician, I think that's especially important, and it's an ethical requirement. So we also want to make the idea of sexual addiction or compulsivity to be open or accessible to persons who are non-binary, who are gender fluid, or their sexuality is more fluid as well. And that's a contemporary development. Then the thing that sort of was really set in motion the great deal of attention to sexual addiction, especially in the media, had to do with internet pornography. And Al Cooper, in his classic works, looked at the AAA engine of anonymity, accessibility, and affordability. So there are all kinds of places on the internet one can go, and most of them are free, although some people move toward paying for more specialized or desirable type of services. And of course, that's one of the economic reasons that pornography more or less pays for the internet, and then the advertising and so forth. All right. So again, some more contemporary models. We touched on there the biopsychosocial model, and Samanow, who is the previous editor of Sexual Addiction and Compulsivity, a brilliant physician, has looked into that. Then we look at Kafka's work in terms of hyperactive sexual behavior, and so there are certain neurotransmitters, and even testosterone may play some influence. I'm one who doesn't really like the over medicalization of all different kinds of mental disorders, because things can be descriptive, or you might say accurate or true, and they don't have to be borne out or supported exclusively by underlying medical findings. So whether it's physiology in terms of some of these brain substances, or it's cortical activity or deeper brain activity that could be picked up through imaging or measuring firing of neurons, that's not exactly where sexual addiction and compulsivity exists. It exists in the lived experiences of those who present themselves for some kind of treatment because they're suffering. But I did want to share these models, and I think, again, I'm weighing in with an opinion there. But sexuality therapy in general has been overly medicalized, and a lot of it goes back to really the innovation of the little blue pill. So Viagra, almost kills sex therapy. Okay, so there's hypersexual disorder, which I've mentioned. There are some of the diagnostic criteria that may apply. So the excessive time, preoccupation. Also, on the low side, using sex to cope with negative and aversive mood states, having these repetitive fantasies, and then the urges that follow from them. Those irresistible urges are very characteristic of compulsive sexual behavior. And then here's one that's, about the powerlessness, attempts to reduce or control sexual behavior, and without success, you see. So a person comes in, they say, it's not, I don't believe it's good for me or my relationship to be spending these hours looking at pornography, and I've attempted to stop and I'm unable to do so. So that's the way I would approach the case. Is this person is saying they need help in getting off of the internet pornography, and I would like to make available a wide range of different options without necessarily pathologizing that person, labeling them. It's from their own experience. Then, of course, A5 refers to consequences. So here's the World Health Organization, or WHO, and their ICD-11, and there is the most recent description. This will be an ICD-11. It's going to take a while to be implemented, but for those who are looking for recognition of compulsive sexual behavior, here it is. And again, I won't read this long list, but it pretty much covers everything we've said up to this point. Now, the thing I would like to highlight down here at the bottom, I'll have to move my QA screen again, is that the distress experienced with compulsive sexual behavior disorder is not entirely related to moral judgments or disapproval about sexual impulses, urges, or behavior. It is not sufficient to meet the requirement. So just because someone says, I'm sexually addicted, or I have compulsive sexual behavior because I'm engaging in looking at explicit sexual material, and it's inconsistent with my faith tradition, that in and of itself, according to this definition, wouldn't fit the disorder. Or if someone else were to label the behavior, let's say a person goes in and they speak to their minister or priest or rabbi, and they say, you know, I'm doing these things, and then the person says, yes, but it's not permitted, then that would in and of itself constitute compulsive sexual behavior disorder. It does sort of highlight, you know, that there are parts of the person that are in opposition, at least in the current expression of oneself. So that's a very important clarification. Now, you know, as the editor of Sexual Addiction and Compulsivity and a member of SASH, we have taken position on sexual health. I think is very important. I'll be sharing that later as I get moving a little faster with these slides. But the mission, you know, is to promote sexual health and to address escalating consequences of problematic sexual behavior that does affect individuals, families, and communities. Seeking collaboration among clinical, educational, legal, policy, and research professionals, SASH advocates a multifactorial approach to address what we call problematic sexual behaviors, further research, and to promote sexual health in general. I think that's an omnibus sort of vision or mission statement that permits a lot of latitude. I don't really think it's inconsistent with the AASECT statement on sexual addiction, but, you know, I would leave that up to AASECT member, you know, to reach their own conclusion. So now this is a great work. Actually, Bill Herring's article on this framework for addressing problematic sexual behaviors recently was voted the article of the year for the Sexual Addiction Compulsivity Journal. And I think this really helps to just kind of make it easier to understand as we move forward now toward treatment. So if we get away from all of the underlying neuroscience, medical evidence, if we don't have to rely exclusively on test data and whether or not someone scores in a clinical or pathological area on the test, or whether or not it's producing these severe, you know, relational, vocational consequences and so forth, we could just look at problematic sexual behavior and really across some very simple domains. And so one of the great things Bill Herring did in identifying these things is sort of say, you know, you don't have to have any particular theory or model. If you're working with someone and they come in and they say, you know, I read about sexual compulsivity, you know, I think I may have it. It's really hurting me. It's hurting my family. I'm having trouble at work on account of it. And, you know, then you just start interviewing and listening. Are you keeping your promises? So does the behavior conflict with a person's commitments? The commitments that they've made freely in their life. Okay, does it conflict with a person's values? Are you okay with what you're doing? And the person may say, yeah, I'm okay with it, but, you know, my partner who's very religious says it is a disease or a disorder. So see, then you've got a process and going through to try to clarify who needs the help and what help is needed. You know, and in effect, who is the client or the patient? Also, conflicts with a person's self-control. Are you in control of your sexual behavior? If you're out of control, if you can't freely make a choice, if you engage in behavior without intention or contrary, you know, to one's own plan or desires, then that in and of itself may say, yeah, I think that's a problematic behavior and we can do something to address that. Of course, does it result in negative consequences? That's classic addiction there, the unmanageability component. And then the last one, very important in terms of ethical approach, does the sexual behavior reflect a fundamental lack of sexual responsibility. In other words, are you creating the potential for harming others? And we unfortunately, have examples of that come up where someone has a lifestyle that, let's just say that it increases the risk to a partner of contracting a sexually transmitted infection of one type or another. And so, that makes it potentially change-worthy, but it especially means that we need to take a look at that as it's being presented as perhaps problematic. Back to the future. Okay, Freud, in the original model that he articulated, primarily from his own abuse experience and his self-analysis, and then later on in working with those early clients or patients or those in analysis, he discovered that when there is a premature or overexcitation of a vulnerable nervous system, and this is usually visited upon a child or vulnerable person by someone who would ordinarily be charged with the responsibility of protecting, that person, and the betrayal that follows from that, that's what creates trauma. So vulnerable nervous system, and we have from Bessel van der Kolk and many other trauma experts who say, yes, this affects the development of the nervous system. And then even more, the sense of betrayal. So that's where trauma originates. And our model, which Mark Schwartz and Dr. Masters, Lori Galperin, and others, Dan Glazer, another of my great colleagues, saw Dan recently, really enjoyed having a chance to speak with him. So, we felt like the underlying problematic or compulsive sexual behavior, that there was probably some type of unresolved trauma that interfered with the development, sexual development. And then Freud also described, and I'm somewhat psychodynamically oriented, mostly nowadays through contemporary object relations theory. But Freud said way back when, and I basically consider all psychotherapy a footnote to Freud, but he described a repetition compulsion and to explain why does a person repeat behaviors that seem like they were associated with the original neglect or abuse or trauma. And he described it as though someone is trying to return to the scene of a crime, or that they're trying to gain a sense of mastery or resolution over that underlying trauma. So there are reenactments. So if there's trauma and then sexual addiction, two sides of the same coin in my estimation. Now, I have colleagues telling me that especially with the internet, people are getting hooked into compulsive sexual behavior and there's no history of trauma whatsoever. But then I would say, okay, and this comes from my work with a wide range of substance use disorders and other behavioral addictions, the addiction itself may produce the underlying negative consequences that are increasingly associated maybe with traumatic loss of nutritious and healthy life experiences, or interfering with development. But I have a bias in viewing sexual compulsivity as somehow being a function of, which I would generally call life trauma. That may be too broad, and I would accept someone's criticism of that idea. But that's sort of my model for starting case conceptualization. So this says the same thing, and this accounts for it. A lot of compulsive sexual behavior is intergenerational. It's a shame transmission process. And the two other things that I would say here are that as you begin to work on any type of trauma, then whatever the person's addiction may be, it's going to increase the risk of relapse. So a person needs to have a very strong recovery program in order to be able to go deep or to address underlying pain and shame from the past. On the other hand, as addicts, various substance use disorders, alcohol, opioid addiction, and so forth, or behavioral addictions, let's say like even something like eating disorder, self-injurious behavior, compulsive shopping. So see, I define behavioral addictions pretty broadly. But as a person achieves more and more abstinence and then sobriety from their addictive behavior, guess what? Trauma will out. So trauma emerges in the life of the recovering addict. And in particular, the sex addict or sexually compulsive individual in recovery, we don't need to be necessarily, going to extraordinary means to find the trauma. The trauma will emerge as part of a natural healing process. So if recovery contributes to intrusive recollections, anxiety and distress and so forth, or if trauma treatment encourages use of an addictive behavior in order to fix feelings and ward off the pain and shame in the past, we're looking again at two sides of the same coin. This is what gave rise to our integrative treatment model that Mark Schwartz originally innovated, is concurrent treatment of the sexual addiction. And very frequently in the past, there was sexual trauma. But we found that there are many other traumas, and really the adverse childhood experiences research has been informative. Also, the adult attachment literature looking at the insults and the neglect and offenses and so forth that interfere with a capacity for intimacy and attachment, they kind of informed this basic model. But that's where it started for us. Not everyone feels that way. So there's a little bit of the statistics on various process addictions. I'll introduce another bias here, and that I believe that someone who really has a significant amount of unresolved life trauma, that they probably have what actually Arnold Lazarus in his model from the past, multimodal therapy, he described a firing order of different problems. So as you address them, you could successfully deal with one area that has been problematic, and then here comes the next. So I believe that's true in many cases of underlying trauma, that there's a firing order of maybe even 3 addictions that line up. And I don't want to spend too much time talking about that because it's an opinion, but that's what I look for. So I guess the main takeaway from this is that a lot of people have behavioral or process addictions. And if you successfully treat one of them, I wouldn't be surprised if here comes another. And especially if you do a history, you're psychosocial, and you find out that someone previously had an eating disorder, or maybe they were previously troubled with workaholism or whatever the case may be. I wouldn't be surprised if you're successful in getting greater stability dealing with a problematic sexual behavior. Well, here comes the next one. There's another question here. Using Freud's definition of trauma, would children's early exposure to internet pornography qualify as trauma? And that's, in my view, absolutely true. The immature, brain of the child, which is still forming connections, neural connections, can be very much adversely affected. But if you move up from the physical level up to the level of cognition, and that's where I would probably rest my case, a child doesn't have the language and doesn't have the experience, doesn't have the categories. They're not able to channel pornography and to make any sense or meaning out of it. And I view it as probably very disruptive of a child's, not only their sexual development, but it may also be very disruptive of other aspects of their development. I think that there is probably quite an overlap, for example, in early and especially continuous exposure to pornography, and not only problems of sexual addiction, but it may contribute to ADHD, you see? And I would defer to my colleagues who are experts on dealing with pornography and the adverse effects, not only on children, but on adolescents whose brains are still forming. And so I would encourage you to visit the SASH website, and it's not a commercial for SASH. It's just there's a wealth of information there now about the possibility of pornography hurting children. So yes, my simple answer to that is I think that kids are at risk for getting online and being harmed by it. So we have Jessica said pornography is a powerful medium, especially early exposure, and then the aggression, the degrading, violent content absolutely is an original source of trauma, and so it's an indirect experiencing of life trauma, a type of secondary trauma. Seeing more of this with younger generations. I'm in agreement with that. And I've worked a lot with kids who are in the juvenile correctional system. And whenever they are having not only sexual problems, but relational problems and even aggression, a lot of times it is associated with some of the things that they, have seen and experienced vicariously by way of, the internet. Now, having said that, I'm a rather liberal person, and I kind of recoil from the idea that we have to put restrictions on the internet. But I wish that there was some way that vulnerable children would not be so influenced and possibly harmed. So, and I'm learning, more about that. Okay, and I want to I'm going to move a little faster so we can get to more of the treatment. But Robert Stoller's perhaps, along with John Money, two of the scholars who have addressed problematic sexual behavior and sexual addiction in ways that have really informed me. Now, having said that, by way of disclosure, when I was working in the Masters and Johnson treatment program, I operated the sexual arousal reconditioning laboratory. And a lot of that had to do with sex offenders. So you get nearly 100% agreement that if you have a pedophile, that it would be very beneficial that they don't have sexual arousal or interest in children. But as you move away from that variant sexual preference, or paraphilia as they're called, then you get a lot less agreement on what is change-worthy. So I can remember doing some change in the laboratory at the request of a patient, but back in the day, we probably should have explored how the person could have a more congruent and lifestyle consistent with their values, and they may not want to change all of their behaviors. Back even in the 80s, there was a moratorium on use of arousal reconditioning with persons who had a same-sex preference, because the fact that it was unwanted or problematic was viewed as part of the coming out process. And I think we're going to have a lot more of that today as people explore their gender and relationship and sexual options. We don't want to impose a treatment technology that could be effective whenever a person hasn't had a chance to really explore who they are. But having said all that, Stoller's main idea was that mostly perversion, which is kind of an emotionally charged word, but it's an eroticized form of hatred. So when you get a convergence of eroticism and aggression, and so back to the previous comment or question, whenever you're looking at like violent pornography, and then at the same time your erotic preferences are being formed, that association is highly likely to produce something that is very difficult to change, and it may produce a kind of drivenness. It may produce shame, but it may not. And you find in the history of some sadistic individuals, serial killers, sexual sadists, and so forth, that you get that eroticized form of hatred. But it applies to other problematic sexual behaviors as well. And I learned a lot of this just from being a behavior therapist in the laboratory. I like to joke, I'm a recovering behavior therapist. I didn't believe in the concept of mind until I discovered I had one. So that's, I've learned so much about therapy from letting go of what I thought was the technology of behavior change, but I don't want to get rid of everything. I want to continue to be open. And the idea of a paraphilia, I think informs, the extreme case informs treatment of less severe variations on the sexual compulsivity theme. John Money's model really was predicting a lot of things that happen in cognitive psychotherapy and so forth. And he developed the concept of love maps. Patrick Carnes picked that up and included it in some of his work. We always included it because Dr. Schwartz studied with Money at Hopkins. And of course, you know, there's a lot of controversy around Money's work, but this idea of there being a template that organizes development of sexual schemas, that's quite important, because a schema is like, it's a filter, and it permits certain information to, you know, get into the cognitive template, and you only admit that information that confirms the bias. So that's called a confirmatory bias, and it excludes information that might be potentially informative or corrective. So it's almost like the case of an ego defense. It works and it maintains the problem. So we want new information open in the channel, we used to call it, to come into the life experience and the perception of someone who's suffering with sexual compulsivity, and they may come to view their sexual lives in a new way. So that's the relevance for treatment. Okay, so this is our treatment model way back when. Manifestation of damaged development of affectional systems. We have several publications in books and journal articles that address this. Surviving lack of bonding, neglect, or abuse early in childhood contributed to problems of affect regulation and increasing dependence upon addictive disorders or processes in order to cope with overwhelming interpersonal experiences. So ongoing problems with attachment impair self-development, and then here comes disrupts the capacity for intimacy, resulting in lack of empathy for oneself or others. Lacking empathy in self-compassion, as Neff has described it, it makes it possible to objectify oneself and another person. But if you have very little capacity for having emotional or physical closeness, and therefore you couldn't enjoy even the freedom to choose an intimate relationship with a partner of that you might select, then maybe that in and of itself identifies a problem, or it makes change-worthy some aspect of that individual's life. So a lot of the clinical cases presented are, you know, based maybe on severe consequences, but some of the cases they're probably typically you know, presented in marriage and family practice, like in couples therapy. You're gonna, if you look around and really examine sexuality, which is pretty rare in most clinicians' experience, but when you look, you may find that there is some problematic sexual behavior, which is kind of a defense against the demands of intimacy, being truly physically and emotionally close. And then if you continue to look at it, then the person may say, you know, we need some help, you know, with our sexuality. Typically, somebody presents with, you know, conflict, arguments, disagreements, but since, again, affairs are so commonplace, infidelity, when that's presented, I would say definitely, I would recommend to take a good sexual history and to make sure that you're uncovering, you know, some of the barriers to establishing and sustaining, you know, genuine intimacy. One of the great characteristics of Masters and Johnson sex therapy model is the belief that if you were to remove the barriers, then a person may have opportunities to gain new experience. They viewed that the natural sexual inclination would emerge. That has become controversial because the Masters and Johnson model, as helpful as it's been, was based on patriarchy, heterosexism, you know, and some other biases, just to be fair. Okay, and then I think, you know, I don't want to read from my own work there, but I tried to say it a little differently, and, you know, based on Winnicott's object relations. And I do think that it's very important to engage creative resources and spiritual resources in healing because we have to have something to hold all of this disorganized experience with sexuality and intimate relationships. Also, we need to reduce shame, and I believe that especially in terms of one's spirituality, that there's great opportunity for lifting the burden of shame. So I'd like to say more about that. I've been doing programs on sexuality and spirituality. Marcus Earl, in the field, has done some extraordinary work, and Ralph Earl, in addressing, spiritual issues in terms of sexual addiction and compulsivity. Okay, so here are some of the treatment components. I think we're moving along now at a pretty good clip. Let me see if there are any other. Oh, I've got one down there. Let me see if there's a question. Okay, John says, is this where we hear the saying in addiction treatment, a drink is a drug, is a cookie, is a flirt, is a bet? Okay. I'd have to think on that one a little bit. I do think that people have love affairs with their addictions, and it's really hard to invest the eros, or the erotic life energy, in other attachments whenever you've invested it all over here in one's drug of choice or in a behavioral addiction. And of course, this erotic life energy, libido, eros, it's a natural to invest it in some type of sexuality. And then that's part of I think the evolution of sexuality. But when it gets invested in a compulsive sexual behavior, and especially one that is hidden or secretive, now we're getting into an area where that eros cannot be invested in truly intimate relationships. There's not enough eros left over to invest in one's own personal development. And, there may also be problems in letting oneself have new life experiences. So that's the way I'm going to respond to that one. Okay, recovery from sexual compulsivity. Address the underlying trauma. You want to disrupt repetition, compulsion, and reenactments. So that means you need enough structure in an environment and a willingness on the part of a client or patient to stop acting out the behaviors in order to get at what may be fueling them, in the psyche. Then you want to establish some secure attachments. That's initially manifested in the therapeutic alliance, and hopefully, the therapist is also able to sustain an appropriate, sufficient amount of closeness with someone, and to build up this a little nest. So, because I say we work with children of all ages. And another way I like to say is we need to make a little nest for the baby bird. So people come in, usually in their pain and shame. We're privileged that they are willing to share with us their suffering, and in the process make themselves vulnerable. And then we need to be able to be present and to be helpful, and to have appropriate boundaries so that we can show them other ways and support their journey. I think it's very important. We had a great program at our recent SASH conference that had Jess Montgomery, Mary Dietz, and me. We did one on the sexual development of the sexuality therapist. And of course, in AASECT, the sexual attitude reassessment, and almost constantly looking at one's own sexuality as a source of bias, but also as a source of healing, hope, advocacy, and so forth. But in sexual addiction treatment, it's very important to look at countertransference issues. And I think especially if you come from a religious or faith tradition that might tend to pathologize, a range of sexual behaviors that really would not be sexual addiction. Yeah, okay, and then the clarification there from John, multiple addictions, any port and storm. I understand now what is being said, and that's true, And I'll just throw in a quick clinical comment. If you work in addiction treatment, let's say residential, if somebody's gotten sober, they're addressing, the things they need in order to heal, guess what? Here comes the 13th step, or a treatment relationship. when it's secret, it derails the recovery process. And, you know, the slogan, we're only as sick as our secrets, I think it definitely applies. So it's to be predicted. So I was working at Next Step in Hattiesburg, Mississippi, which was a residential treatment facility with Forest General Hospital. And the director of the center said, you know, Stephen, I wish you'd come over and do a sexuality and relationships group, because, you know, at one particular time, and when the program was located in an apartment complex, nearly half the residents had gotten involved in, you know, sexual relationships. And we talk about in recovery from substance use disorders that a lot of times those new to recovery especially are in adolescence. And so we think adolescents want to explore their sexuality right now. So that is a risk factor, and it'd be great if we're prepared to address, you know, the potential for there being some the potential for there being some compulsive sexual behavior, and to set up appropriate boundaries. Let's see, we've got another question coming in. Jessica. Hey, the question, I'm going to paraphrase it. So what if somebody, they've had an extramarital sexual desire or actual behavior, act on, you know, urges or desire, then they come into treatment, but they continue to question or even deny that it's a problem. And of course, you're going to see that in clinical practice, especially in couples therapy. It's a one-time event. It reflected this, that, or the next thing. It doesn't mean that I actually have any problem with sexuality. It'll never happen again. You know, multitude of explanations and maybe excuses. But what I would say is, if you get a good history, and chances are, if someone is really committed to exclusivity in a marriage or a committed committed relationship, and they violated that boundary, that didn't just come out of left field. There's going to be a lead up to that, and you're going to gather some important information. And then the process of gathering that information, really just laying it out, it's like, okay, this is your life, and what do you make of it? So back to the motivational interviewing kind of thing, I think a person may come to see that, yeah, you know, this is something I need to address. Maybe it only happens one time because that's the person's goal, but I bet you there's a little bit of a history there. Okay, moving a little faster. We want the secure attachment, the treatment alliance, maintain emotion regulation. DBT, in my view, is essential. Now, I know a lot of people don't feel that way, but DBT is evidence-based. It's very portable. It deals with impulses and a lot of out-of-control behavior. But guess what? This is something I'm quite excited about in my own practice, that the radically open DBT addresses the other side of addiction. So if on the one hand, DBT helps with emotion regulation for out-of-control behavior, then radically open DBT addresses the over-controlled, overly restrictive, narrow type of behavior that leads to emptiness, could be associated with depression, self-injurious behavior, suicidality, and so forth. So when you have a combination of dealing with out of control and over control sexual behavior, then I think that's going to be the most effective. I wish I had more time to talk about that, because I'm thinking the radically open DBT is a missing component in a lot of sexual addiction treatment programs. Okay, then reconstructing the erotic template. If it gets skewed, twisted, if things get omitted, if things are non-sexual, like in fetishes, get displaced into John Money's love map or erotic template, and it's there, it's like, well, how do you change it? And in a few minutes, we'll be talking about some of the, what I call instigative or more intensive methods for healing a person's self. And in general, exposure-based treatments are some of the more effective instigative methods, like EMDR or like internal family systems or schema-based therapies, even aspects of emotionally focused therapy. That unheats, unfreezes habitual thought processes. So by increasing the internal distress or anxiety, or increasing access to formerly walled off or siloed components of one's personality or of oneself, it unfreezes habitual cognition, and you can help to put in new information. I wrote an article years ago on sexual addiction treatment being a benevolent form of brainwashing. And I compared the treatment to what is known, from Edgar Schein, Baumeister, and others about a brainwashing process. And I don't want you to take away, well, Southern, he brainwashes patients, but how people change their minds, that's what I'm getting at. And as long as we have informed consent, we have appropriate boundaries and values, and people are, really free to choose, there are ways to change even some deep-seated templates that limit experience. I'll leave it at that for now. Probably shouldn't have shared all of that, because I'll see if I've gotten any negative comments yet. Quit brainwashing people. The critics of sexual addiction do claim that it is a brainwashing process. So develop coping, social, and life skills. And then I think at the desired end of any effective treatment is to restore a capacity for genuine intimacy. The person's life may be so damaged that it's very hard to even talk to people. So you have a building block approach, or really you're going back to the place where the person left off in their development and making age-appropriate learning experiences, which may just be, carrying on a conversation. We had that in our treatment program in New Orleans. We had occupational therapists who assisted, some of the individuals who really had not developed very much interpersonally, so that they could practice very rudimentary skills. And nowadays, and I want to, mention this for our audience, I think the movement in life coaching is really going to help tremendously in assisting individuals in building their interpersonal skills and moving on in their development toward more fulfilling lives. Okay, so here's another way: recovery from sexual compulsivity. We've got the attunement with a therapist, emotion regulation, getting some choice process out of over-control behavior, starting to remember events from the past and probably recording them. We used to record them through writing. Sometimes people do collages. That Harmony Place, they use a lifeline approach. I think that might be Pia Melody, I'm not sure. But we used to use a narrative, because I like narrative therapy and telling one story. But you're going to have to put it into context when people start remembering their past traumatic experiences. What I like about narrative therapy is that we can help in co-constructing, a new story. That helps to gain mastery over reenactments or repetition compulsion. There is the narration of the emerging story. I'm biased in that direction. We want to overcome some of the bias and distortion that the person presents, get these life skills, and then as you move on through there, through intimacy toward healthy sexuality. So in sexual addiction treatment, if the therapists were adequately trained in sexuality therapy, I would guesstimate that in maybe 50% or more of the cases, toward the end of treatment, there would be a need or opportunity for sex therapy. Okay, I'm going to move a little faster for the sake of time. I do appreciate all the questions and comments. But the shame is at the core of sexual addiction, this pervasive sense of being bad. And I've never found a better book in all the years than Fossum and Mason's book on shame and family systems. And so it's such a profound, humiliating inward experience that people would do nearly anything to avoid contact with it. So we have to find a way to help a person to deal with the shame immediately upon entry into treatment. And for good or ill, the best way to do that is in group therapy. And the groups need to be safe. They need to be confidential. They need to create opportunities where secrecy can be revealed as in the right time, by the person, recovering person. They overcome their isolation. They see that other people have also experienced this. Hopefully there are some models or persons who have made progress and they're doing well in their recovery, and there comes the 12-step groups. I really strongly recommend participation in a 12-step fellowship for compulsive sexual behavior. And the Sex Addicts Anonymous is kind of a mainstream group. Sexaholics Anonymous has, I guess you might say, as part of their group conscience or their traditions, they have stricter boundaries. And then Sex and Love Addicts Anonymous is a very broad, very open, fellowship and looking at sexuality and intimacy. There's also Recovering Couples Anonymous. There are a few meetings in Mississippi. I don't know if there would be any in your area, but especially for those couples who are hurt from sexual boundary violations due to sexual addiction, and maybe you have the partner then who is experiencing possibly even some post-traumatic stress disorder and seeking after his or her own treatment. And then these couples, they can put their relationship, into recovery. Very important because of the opportunities for meaning making, for shame reduction, and for relapse prevention. Then couples therapy, need a collateral contact to get a sense of the scope of the compulsive sexual behavior early on in the treatment process, but you may delay couples work or any kind of family work until a person is more stable. And also the disclosure process, it's stepwise. Jennifer Schneider and Deb Corley have done a great job of describing this process. So it should not be done in a way where it's harmful to anyone. And if it is a process, then there's the right time and the right place, but we don't want to encourage secrecy or hold secrets. So it's a delicate balancing act. And if a person is in a committed relationship, you know that there needs to be some healing there based on, some compulsive sexual behavior. So assessments, various tools, most of them either help a person to self-diagnose or they use various addiction diagnostic criteria. And increasingly, there are some scales or instruments that are available to look at particulars dealing with pornography, because pornography addiction, for lack of a better term, is now becoming such a big problem, and it has some of its own, special characteristics. And I think there's a comorbidity there in just being dependent upon technology, screen time, internet, social media devices, and so forth. So here are some of our treatment components. I think I'm getting to the stuff I think you're probably more interested in. I apologize if I spent too much time dealing with the nature of the problem and not enough the solution. But if you look at it, you got to facilitate a healing process. I want to emphasize here graduated self-disclosure instead of forcing people to disclose and regret, what they shared, to feel consumed by shame, and then to go out and relapse. So wouldn't that be, sad that the treatment process itself becomes the motivation for relapse? So graduated self-disclosure, slowly turning up the exposure to, trauma experiences, but we don't want to wait indefinitely or view the person as being incapable of healing or overly vulnerable or, needing protection. That probably has more to do with the codependency or co-addiction or the countertransference of the therapist when you're trying to hold someone back from trauma that they really could otherwise address. When you're, another comment, when you say to someone you referred to SA and they say, I can't, I know why I would be going, so I don't want to go. I know what I would be trying to do. There's a lot of resistance to going to 12-step groups in general early in recovery, but if a person makes a commitment as part of a treatment plan, And the convention is to visit, at least 6 groups. And it may be for persons who are possibly exposed to attention that would interfere with their family or their work or schooling or something like that. Maybe they could go, to a more private place. I appreciate that. But, visit these groups and come back and then tell the therapist, what was your experience? What did you find? And if you'll give them a challenge of going to 6 meetings or even 6 different groups, hopefully they'll find something there that will help in relieving the shame. But the shame itself is what keeps them from the willingness to go. And once in a while, you'll get someone who really, they're going through the motions of saying they will change, possibly to try to satisfy a partner, family member, job requirement, something like that, but they really have not reached that level of motivation. So you're back to the stages of change model. Okay. Then in implementing change, here comes relapse prevention. Should start on day 1 and continue right through the treatment process. Now we're starting to deal with all the co-occurring syndromes and disorders, the complexes of the psyche, the personality disorders. We're providing psychoeducation and understanding sexual compulsivity. And then here comes a really, really important component, mindfulness. And the mindfulness-based stress management, mindfulness meditation, all of the variations on that theme, yoga, somatic therapy, body work, anything that can help in calming, those old parts of the brain that are interfering with a person's ability to take in new information, process it, and make some intentional choices. Also, having access to mindfulness, even within the DBT framework, is going to go a long way toward deepening then of the inner work, maybe dealing with part personalities, ego states, internal family systems, and so forth, or using exposure-based treatment without precipitating relapse. Okay, so let me go back for a minute, pick up for, that's forward. Yeah, so we're facilitating healing and then hopefully engendering greater hope. And that would also come from attending 12-step groups, because you see people who are making it and you hear stories that are meaningful. Then you're implementing this change process, addressing depression, anxiety, beginning to address the nature of the compulsive sexual behavior itself. You deepen the relationship. Hopefully there is a meaning-making, philosophical or spiritual dimension, to the treatment. Again, that's my bias, so it may be, a preference more than a requirement. Then you start reconstructing the self. So within the personhood or self or psyche, within the damaged object relations, all different, language applied, but they're dysfunctional schemata that unless they're changed, the person remains vulnerable to reenactment or repetition compulsion of past trauma. They also remain very vulnerable to relapse. So the goal of integrative treatment, concurrently treating underlying neglect, abuse, and trauma, and then treating the sexual addiction and other behavioral addiction, the mediator in that process will probably be reconstructing the self. So in Mark Schwartz and Lori Galperin's program, they offer a wide range of different experiences, including EMDR, which is an evidence-based approach to dealing with traumatic stress, and also using internal family systems therapy developed by Dick Schwartz. So those are a couple of the means. I'm more inclined to use like FOA's prolonged exposure, and there are many, I would use the old Buddhist expression, many paths to truth, one truth. All right, and that truth is that we have to get at that which would otherwise be avoided. The whole lifestyle of an addicted individual is organized around avoiding the pain and shame of the past. And if we have only superficial treatment, skill building, and I would say even, CBT can be rather superficial unless it's based on a foundation of reconstructing the self. So even as a behavior therapist, I would say CBT is necessary but not sufficient. And then, you know, continuing this life history narration, telling one story, doing the lifeline, and continuing to enlarge that appreciation about what happened. So basically it's, you know, the past, present, and future as part of one story. And then finally, reconstructing family systems. And, you know, the therapy could be introduced within residential care, partial hospital program. It could be introduced at some point in regular outpatient care. Definitely if someone were in a hospital where you have a high degree of structure and you can handle the outcomes of having exposed someone early in their recovery process to the potential disorganization of an addictive family system. That's my only caveat, is that family therapy can set off relapse behavior if it's implemented too early or if there's too great of a focus upon it. So another more or less preference or bias. But we do want to move toward involving more family members. Years ago, I had a group for sex addicts, and we started including the teenage sons with their fathers in the group. And it was because we were finding a lot of evidence that the children had already received the intergenerational legacy and were beginning to act out upon it. And it was a very, very interesting and I think beneficial group. I haven't done one recently. Okay, so here's your basic treatments: prolonged exposure, cognitive reprocessing, excellent model, EMDR, internal family systems, Jeffrey Young schema therapy, and a particular model that's manualized and evidence-based that I like, that would apply to many aspects of trauma and addiction, is Najavit's Seeking Safety. And she's had a website in the past where she's very generous in sharing many of her resources, and then all of these, you know, these experts and you know, the innovators, they make available their treatment manuals and their workbooks, and you know, for the most part the process is reachable. Various pharmacological treatments, and you know, of course, naltrexone being used a lot to deal with urges and block that reward system. Anofranil, very helpful in dealing with compulsive sexual behavior where there really is a strong obsessive compulsive dimension. All of the SSRIs have some potential for reducing, you know, the preoccupation, for reducing anxiety that might feed into greater risk for relapse. And Topamax, I find in the literature, has been used for multiple behavioral addiction. Let's see. I don't know if I wrote a chapter in this book. I don't know if you can see the title of it, but it's the Routledge International Handbook of Sexual Addiction. So it's a UK book. The Brits published it, but it was this last year. So it's a very good, although somewhat expensive, like encyclopedia, and it would include additional information on pharmacological treatment, as well as all of the different treatments. Then here's some specific forms of treatments you could find in that book or in the literature. Carnes' 30 task model that they use in training the certified sexual addiction therapist, and his work over time. Dr. Carnes has really provided a lot of useful material for clinicians and for recovering people. Mentioned mindfulness meditation, various types of creative arts therapies and experiential therapies, and including like psychodrama and expressive therapies, especially for dealing with family of origin issues. Brown Harvey and Vigorito, they try to use a cognitive model for overcoming out of control behavior and in introducing intention and deliberation and making decisions. And then, the mentalization model, Fonagy and the colleagues in Britain, the work they've done with children alone, just in helping to understand how they come to form their, cognitive experience and capacity for relationship. Here are some special populations. So, there's the general issue, does sexual addiction compulsivity exist? If it does exist, what are the characteristics? If we agree these are change-worthy behaviors, what would we do in general? But are there any special considerations for certain subpopulations, you might say, of persons who deal with sexual compulsivity? Adolescents, definitely. And that early exposure to internet pornography and, co-addiction to social media being really critical factors. If we don't address them in adolescence, we're going to see these problems emerging later in adulthood and producing maybe some profound consequences. Also, something I want to highlight in case I haven't or run out of time. There's an increasing literature to show that among adolescents and young adults, and particularly men, that extensive involvement in internet pornography with masturbation and so forth, that it is so affecting the brain, I think also the sexual schemata and so forth, that we're seeing increase in sexual disorders, including erectile dysfunction, like in teenagers and young adults, college students, and so forth. And there's not really an organic cause. We now view erectile dysfunction as being, probably related mostly to aging and chronic health problems. But this is very, very interesting. Internet pornography exposure over time can interfere with sexual functioning. And so when I'm talking with teenagers or young adults, even if they're not experiencing some of these symptoms, then I want to make them aware of risk factors. Then dealing with women, there's examples there of boundary issues, caretaking, codependence, various expressions of what would be more acceptable within the traditional gender orientation, although not bound by that. Men who have sex with men, this is another population very important to address, not only problems of internalized heterosexism, worm in the bud kind of phenomenon, but also looking at the various sites, the locations, the geography of how sexuality is expressed, and whether or not that contributes to higher risk of compulsive sexual behavior. And especially now with PrEP and ways of reducing risk of HIV, I think we're going to see a new increase in a lot of at least very active forms of sexual acting out in ways where safe sex may not be practiced. Clergy, we mentioned that earlier, 40% of pastors had sexual contact with members. And that's from that article, which I think will be in the references section. But that's probably broadly defined because there are a lot of sort of vague boundary violations. But this would include also hands-on violation affairs that really destroy person's ability to benefit from participating in a faith tradition. We see, almost the undoing of many aspects of Catholicism due to the increasing awareness for those who were not already aware of the sexual abuse perpetration, by priests and religious figures upon vulnerable children. Okay, and then professional sexual misconduct. Samenow and Schneider, they've written extensively. There are various treatment programs around the United States which deal with these impairments. A lot of times they're co-occurring with either depression, bipolar disorder, maybe a substance use disorder, but at times the compulsive sexual behavior may be exclusively the presentation, where a person is traded, prescriptions for sex, indecent touching during physical exams, and some of it's based on this phenomenon of being a wounded healer. And I would refer you to that concept in the literature to better understand the risk factors for physicians and health professionals. And then, of course, sex offenders represent a special population at risk. It's not, we wouldn't say that every sex offender is also a sex addict. In fact, there are sex offenders who are basically psychopaths and criminals. And there is no sexual addiction or compulsive sexual behavior. But there is a co-occurrence of compulsive sexual behavior among some sex offenders. It doesn't excuse or account for the offending or criminal behavior, but it may need to be addressed in effective treatment. And we're about to wind up here. So I will not have the time to address all of the particulars of sexual health. But I do want to say that without attention to sexual health and focusing only on sexually compulsive behaviors, then it's an incomplete model. And so some of the criticisms directed at sexual addiction treatment really were well-founded in terms of, well, then what does constitute sexual health? The questioning. And I wanted to include a couple of slides that are not in your handout because I added them. Again, for the sake of time, I will not cover them. But a couple of my students at Northwestern, they called into question whether or not sexual health even required sexual outlet or sexual expression. And the only reason I wanted to include that is because we're deconstructing sexuality currently in our culture, and this is a good place to start. Because we make the assumption if someone doesn't have sexual feelings, desire, or they don't participate, especially in partner-oriented sexuality, that that in and of itself is evidence or symptomatic of a sexual disorder. And Brenna and Taylor there, they kind of call that into question. There's a whole network there, AVEN. You can look up AVEN online, and that'll take you to their advocacy website. And this is a long vision for sexual health you will have in your slides, and so I won't cover all of it, but we adopted this in SASH after really quite a bit of discussion and negotiation, and so it wasn't an easy process. So that process itself I used when I was teaching a sex therapy class at Northwestern. I sort of shared with them different drafts of our definition or our vision, and they could gain a sense of how difficult it really is to say, well, what is sexual health? And I think all of us as clinicians, we need to have our own ideas about what may be sexually healthy before we start labeling something as a disorder. So that goes a long way to addressing the bias or countertransfer. And then some of the definitions: central aspect of being human, encompassing sex and gender identities and orientation and pleasure and intimacy, even choices related to reproduction. That's the classic World Health Organization definition. And then SECUS has a range of behaviors where you appreciate one's own body, you affirm your sexual orientation as well as the orientation of others. You can make informed choices, that you could express your own sexuality without violating the rights of another, and that you express sexuality in ways that are congruent with your own value system. And here are some of the dimensions of positive sexuality. This was put forth by a colleague, Ginger Manley, and I always liked it as one of the better models. But it starts with physical function, then it moves up to the behaviors of sexuality, then your roles in relationship, and trust, vulnerability, and mutuality are really keynote in having capacity for intimate sexuality. Then personhood, you know, how do you see yourself as a sexual person? And finally, the spirituality, which again, according to my bias or preference, it expresses some of the ideals of sexuality. In fact, I did a sex therapy group for senior or geriatric psychiatric patients, and it was on Saturday mornings at 7:30, And I started the group. It was an 8-week group, and I went in and read from the Song of Songs or Song of Solomon. And it was quite effective. Okay, then Peggy Kleinplatz's Optimal Sexuality, you know, some of the things there that start with just having the capacity to be present in the sexual expression and relationship, and all the way through transcendence and transformation. But we have to remember, you know, sexuality really needs to be fun. It needs to be adventurous and exploration. If we embrace Perel's, you know, model, mating in captivity and so forth. But it does involve a willingness to be vulnerable and perhaps to surrender. And that's where, again, underlying trauma impedes progress toward optimal sexuality. Hey, I finished. Are there any more questions? And there are some of the references there. I think those are useful. They're tiny on this screen. You'd have to probably use the handout and blow it up a little bit to find your reference. But I want to tell you that I thank you for staying with me. I know I've been kind of lecturing. I've been trying to answer a few questions. Hopefully you found the information helpful. I hope it raised more questions that we didn't address, and that you will reflect on your own work as a clinician. If you're a counselor, marriage and family therapist, I can almost guarantee you that you're seeing people who are struggling with compulsive sexual behavior. But if you don't ask them about sexuality, the shame will keep them from volunteering the information. And then for those who present with sexual addiction, sexual compulsivity, we don't want to pathologize them. We want to look at it in context. We don't want to jump to a conclusion that is caused by any particular, you know, underlying disorder or syndrome. We probably want to use Herring's framework to see what is change-worthy. And then we want to be available, because I think it would be a shame if someone were, you know, suffering silently and then finally takes a first step and comes into an office, and we don't believe that it is a problem because of our own, you know, preference or bias, and you know, we don't have an array of potential solutions for them. That's why I like the AASECT model, and I also like the SASH model. I'm a member of both organizations, and I feel privileged to be members of these organizations. So thank you for staying with me today, and I appreciate your nice comments. It's great to be able to still be a professor and a clinician. So thank you.
Thank you so much. Thank you all attendees. And yes, the webinar will be recorded and posted online next week. Each of you will receive an email with that link. And please fill out the evaluation form. That will give you 2 CEs for this program. And also sign up for the next 3 of the webinar series. One's November 16th and December 14th and January 18th with Nicholas Barth, Samantha Young, and Dr. Schwartz on the 18th of January. We hope to see you then. Thank you so much.